Hello and welcome to another lecture for human sexuality. Today we will be talking about paraphilias. Before we get into that, let's real quick talk about how we measure these, or how in a lab setting or in a medical setting these types of paraphilias or sexual attractions can be measured. So we talked about earlier in the semester, we talked about some of the different disorders relating to sexual arousal, sexual desire, those types of things. It's measured in basically the same way. That is, sexual arousal is measured in response to specific erotic material. If it's a normal individual, the erotic material would be for normal erotic material, but if it's one of these paraphilias, which I'll get into in just a minute, the material would be for whatever is causing the arousal. In males, it's typically a penile strain gauge. It basically just measures the amount of an erection. So this is something that can be measured even without looking at personal opinion. So if a male starts to get an erection to certain material, then they derive sexual arousal from that. And again, this isn't necessarily voluntary, it's more of an involuntary thing. For females, it's blood flow to the vagina is measured. So again, this is an involuntary reaction. Let's look at it then. So we're going to look at the paraphilias, mainly looking at how we get atypical behavior. So sexual behaviors that are unusual or abnormal. So typically this is going to involve sexual arousal involving preference for a non-genital sexual outlet. Something that's what would not normally be considered a sexual outlet. Obviously, when we're looking at genitalia, that would be a normal sexual outlet. Even breasts, normal sexual outlet. When we have arousal that comes from other things, whether it's other body parts, other clothing, other objects, other creatures, those types of things, this is where we get into the atypical behavior, because it's what would not be considered a normal genital sexual outlet. And along those lines, you can have patterns of sexual behavior or arousal that appear problematic in the eyes of either the individual or society. And these are where we get paraphilias. So paraphilias, and I'll define it in a minute, but paraphilias are these basically sexual behavioral arousal that either the individual or society considers abnormal, unusual, or problematic. Okay, so looking at this, we've got and this is a DSM-5 clinical description for paraphilic disorders. And what this basically looks at is, in defining it as, is a paraphilic disorder, or a paraphilia, is a misplaced sexual attraction or arousal. It can be focused on inappropriate people, inappropriate objects, and it has a high comorbidity with anxiety, mood, and substance use disorders. So again, paraphilic disorder, paraphilia, is misplaced sexual attraction or arousal directed towards inappropriate people or objects. And objects here is a pretty broad definition. We're going to actually look at these more in just a minute. So going beyond that, so with paraphilic disorders, how it manifests, how it shows itself is fantasies, urges, arousal, or behaviors. So it can be any of these to be counted as a paraphilic disorder. It doesn't have to be just actual behavior. Again, like I was saying, arousal is involuntary. It is possible to have arousal to something but no behaviors relating to it. You can have fantasies about something but actually have no behaviors. You can have urges, and again, we'll come back to this later and look at how the prevalence of some of the paraphilias is actually much higher than those who actually engage in the behavior of that paraphilia. because if we are including things like fantasies, urges, and arousals, and many people, knowing that some of these are wrong, who have these fantasies, urges, or arousals, do not actually engage in the behaviors. Along those lines, paraphilia is not always actually disordered. It's only considered disordered when the individual either experiences clinically significant distress or impairment. What I mean by that is the person it is causing harm to the individual, or it is causing harm to others along those lines. So clinically significant distress or impairment, or the paraphilia is carried out with acts on a non-consenting person. Typically what we're looking at there is those that are underage, but non-consenting can be a broad range of things. It can be someone who has cognitive deficits. It can be someone who, obviously, and we'll come back to this later, but it can be someone who does not consent, things like that. So non-consenting person, either someone who can't give consent or someone who doesn't give consent. So again, paraphilia, it's not always disordered. We'll look at some of these, how they're actually normal when they're engaged on in contexts of consenting adults. So the big thing here is, when we're looking at these different paraphilias, is to be aware that it's not always disordered. It's only disordered if it's causing this clinically significant distress or impairment, or it's behaviors involving a non-consenting person. Here's a list of the paraphilic disorders in the DSM-5. There's actually more than this. The list actually goes on and on, but this is the list that's in the DSM-5. So this is the list that we will examine in more detail. There's actually one that I'm going to throw on beyond this, and then I'll throw on a few after at the end. But the point is that there's a lot of different that would be counted as paraphilias. These are the ones that are looked at specifically in the DSM-5. I'm not going to go through this. We're going to talk about each of these in the individual slides, so I don't need to look at each of these now. Let's start with frauderistic disorder. This is an interesting one. So this is a persistent pattern of seeking sexual gratification from rubbing up against specifically unwilling others. Not willing others, unwilling others. Some engage in this by rubbing up against willing others that are pretending to be unwilling. That is one way that this could be possibly a paraphilia that is not disordered. But in general, people with frauderistic, it's disordered because they're actually engaging in a behavior with non-consenting individuals. So this often occurs in crowded situations, stuff like the subway. It's actually very common in places like Japan, where the subway is crowded, where people with this disorder will rub up against others because the other person can't get away. Next one we're going to talk about, and this one's a broad topic, and that is fetishistic disorder. I can't say it properly right now, but that's okay. And this is going to be sexual attraction to non-human objects. And non-human is kind of a misnomer because it can still be human objects, but it has to be objects that are not normally sexual. So this could be objects that are inanimate, animate, all of these different types of things. Could be a clothing, it could be a fabric, a material, it could be a part of the body again, but if it's a part of the body, it's not one that's normally classified as sexual. So we'll get to that on the next slide a little bit more, but this is when you're looking at like rubber, hair, feet, objects such as shoes. So you see here that even though you've got this included, there are human things here like hair and feet, it's not things that are normally considered sexual. This is one that isn't in the DSM, but I wanted to look at it as kind of tangential with fetishistic disorder, and that is partialism. And this is where you have specific exaggerated sexual arousal to a specific body part. So this is almost a subcategory of the previous one, but it goes beyond that because fetishistic doesn't include things like the buttocks or the breast or specific genitals, whereas partialism can include those, but it's exaggerated. So it's above and beyond what would normally be considered sexual arousal for those. So it can become a extreme focus on one specific body part to the exclusion of others. Next one we're going to talk about is voyeuristic and exhibitionistic. So voyeurism is the observing an unsuspecting individual undressing, either naked or engaged in sexual activity. Sometimes there's a risk associated with peeping that may intensify the sexual arousal. One thing that levels of anxiety can actually increase sexual arousal is one of the things I cut from these slides to make it shorter for the online. But one of the things, as I was saying, that can increase sexual arousal is actually anxiety. So anxiety about being caught can increase the arousal here. Voyeurism is something that typically happens first of the two of these, and what you get here is quite often someone will see or hear something, maybe as a young teenager, and they start to associate that with arousal. We'll actually come back to this when I'm talking about how these different disorders develop, and I'll use voyeurism as a specific example. On the other hand, you have exhibitionism. This is exposing oneself to unsuspecting strangers. So it's not just exposure of genitals, it could be having sex in front of others. And just like the risk of getting caught peeping intensifies arousal, the risk of getting caught can increase arousal for exhibitionism. Next one I'm going to talk about is transvestic disorder. This is when you get sexual arousal from the act of cross-dressing. Sometimes males, and typically it's males who do this. There is instances of females that have this, but it's typically males. We live in a society now where females are allowed to dress in male clothing, but males aren't necessarily allowed to dress in female clothing. So you don't see this as much with females. In other cultures where females are only allowed to wear certain apparel, you see this actually more in those cultures. So again, the males who are experiencing this may, but it's rare, but may show masculine compensatory behaviors when they are not cross-dressing. And interestingly enough, many who have this disorder, if it's going to be considered a disorder, we'll get to that in just a second, but many who have this arousal from cross-dressing are actually married to a woman, and the behavior is known to their spouse. So this is one where within the context of the relationship, it actually may be normal or may not be disordered. So let's get to that. It is not inherently pathological. It is not inherently disordered. It's actually only considered disordered if it causes that significant distress or impairment that we talked about before. If it's not causing the individual distress, if it's not causing impairment in the relationship that they have, things like that, in that case, it's not pathological. It's not a disorder. And this is one of the perfect examples of that, where it could be disordered, it may not be disordered, all depending on that. Is it causing distress or impairment? This isn't one really that's happening with non-consenting others, so we're not going to look at that side of it, but distress or impairment is the big thing here. Next one is sadism and masochism, and again, this is specifically sexual sadism and sexual masochism. This is one just like the last one. It's not considered disordered unless it's causing harm, impairment, or it's happening with a non-consenting individual. The harm here is subjective or relative. because obviously inflicting pain or humiliation, which is what sexual sadism is, inflicting pain or humiliation to obtain sexual gratification, that is inherently causing a type of harm. But if it's not causing the distress or impairment, and it's happening with a consenting individual, then it is then not considered disordered. Which gets us to the other side, sexual masochism, that is deriving sexual gratification from suffering pain or humiliation. And in this case, it is one of those where you get people with sexual sadism and sexual masochism tend to get together because one gets the gratification from inflicting and the other gets the gratification from suffering. And these two come together, and now you don't have it considered disordered. You don't have it causing actual harm in such a way that is not wanted, and it's happening with consenting individuals, so it's not considered disordered. Next thing we're going to talk about is one that really there's no way to get it to look at it in any way other than it being disordered, and that is sadistic rape. When we look at this, though, we have to first classify that some rapists are sadists. Again, we just talked about that, those who get pleasure from inflicting harm. But most are actually not. When we talked about rape, we looked at it in a lot of the cases, the person was actually concerned with the welfare of the person, at least afterwards. Sadistic rape, on the other hand, is where you really have the individual has this desire to cause harm in the act of raping. So sadistic rapists, they actually show sexual arousal to any violent material, so whether it's sexual or non-sexual. So again, sadistic rapists, they derive their pleasure from causing harm in the context of rape. And as I was saying, there's really no way to see this other than as disordered. If the person is engaging in it, then it's obviously happening with a non-consenting individual. And we'll come back to, as this is one, and the Paraphilias is the other, that a lot of the focus of treatments have been on. Let's get to that one then. Pedophilia, pedophilic disorder. So pedophilia, in specifically here, and we'll come back to this, but sexual attraction to prepubescent children. So as we classify it in courts, it's underage children, so anybody under the age of consent. But actual pedophilia is sexual attraction to prepubescent children. I'll come back to that in just a minute, looking at the other philias that are related that can be with non-consenting or those under the age of consent. With pedophilia, the majority are males. In some cases, it's limited to incest situations, so young members of one's own family. It's important to note here that many sufferers do not actually act on their desires. And we go back to that I was talking about at the beginning, when we look at the penile strain gauge, stuff like that, when you can measure who actually has arousal. What is, I think, one of the things that really needs to be differentiated here, and you're starting to see this more in the media and with research, is that what we're finding is that a disproportionately large amount of males actually derive sexual arousal from those that are under the age of consent. We'll come back to that in a little bit more in just a minute. But most do not actually act on these desires. What I mean there is, or what we know there is there's some estimates that as many as 40% of men derive sexual arousal from, or get sexually aroused from, images, at least provocative images, of those that are under the age of consent or those that are even prepubescent. That being said, the majority of them do not act on it, and some may engage in compensatory moral behavior. There's other things that people do, maybe self-harm to stop them from thinking about it. Some donate to charity, some do other things. It's, again, I'm not, and just like when I talked about this earlier when we were talking about rape, obviously this is a abhorrent thing when it actually occurs. I said I would talk about the different philias because um, we have different ones for different ages, such as infantophilia. That's infants and toddlers. Those are children that are less than 5 years of age. Then we have pedophilia. This is prepubescent. Some pedophilia includes everything before puberty, but when we're looking at breaking these down into subcategories, pedophilia is actually just ages 5 to 13. Then you have hebephilia, that is girls that are going through puberty, around the ages 11 to 14. You see there's some overlap here. That's because you can have it classified as in multiple groups. And then you get epivophilia, and that is mid-adolescence, 15 to 19 years of age. I want to point out that this last one, you should understand this now from the talk we've had on evolutionary theory and attraction, that this last one, mid-adolescence, that 15 to 19 years old, past puberty, right in that prime age of fertility, it is, when I talk about that 40% derive sexual attraction from non-consenting, we're really looking at 14 and below. When we look at those 15 and 19, the vast majority of adult males would derive sexual arousal from those ages. And that still doesn't mean it's right, because we're below that is below the age of consent, but need to point out there that that is, when we look at it, that is actually what's going on for actual arousal. There are other disorders as well. I'm not going to go into them really that much. Things like zoophilia. This is sexual urges and fantasies involving animals, or again behaviors as well. There's an interesting gender split here. Men, it's typically with farm animals. Women, it's typically with household pets, those that have this disorder. Necrophilia, desire for sexual activity with corpses. They get pretty bizarre. Nymphomania, excessive sex drive or sexual appetite in women, specifically women. So nymphomania is specifically women. It's basically a sex drive or appetite that's insatiable. In men, it's called satyresis. So it's the same thing, appetite that's insatiable, sexual appetite that's insatiable in men. So these are the two that really some people think they might have, but to be classified as this, it really has to be insatiable sexual appetite. And there are many, many more. I'm not going to go into them. If we were in class, I'd open up this Wikipedia page and poke fun at some of them. There's just some weird ones there, some that aren't as weird. Sexual attraction to people that are older. Sexual attraction to people that are over 70. Sexual attraction to various different objects. And then there are some that are just bizarre. Sexual attraction to the sight of blood. Sexual attraction to various spiders, I think was one of them. That's just strange. But the point is when we look at the list of philias, there is hundreds of paraphilias. And the DSM only looks at a few specifically, and mainly because many of them aren't actually classified as disordered for most people, but they all fall under the same category of sexual attraction or arousal to these non-normal objects. Before I go into the last topic, I do want to look at some of the causes and treatments for paraphilic disorders. So one of the causes is this difficulty forming normal relationships. A lot of people with paraphilic disorders have deficits in typical sexual experiences, or maybe they had relationship difficulties in childhood or adolescence, difficulties in relationships with their parents, difficulties in friendships, difficulties in early romantic relationships, things like that. One is early experiences may lead to associations by chance and then reinforced through things like masturbation. I told you I'd come back to voyeurism. This is one of the perfect examples of this. That is that someone, let's say an adolescent male, he is walking down the street and sees something through a window. Sees a girl changing or a woman changing, or sees someone having sex, or hears someone having sex through the walls, that type of thing. They then, the individual masturbates. There's now this sexual association between this thing that occurred and now masturbation occurs. So now there is sexual arousal. There's this now sexual pleasure is associated with this thing, and it just gets reinforced by occurring over and over again till it becomes a full association between arousal and the object or event that occurred. So this is, again, like I said, where a lot of voyeurism and exhibitionism turn into strong sexual desires. And you can also get this through other things, such as possible abuse. So child being sexually abused, it becomes associated in their mind with the sexual, they associate it with a type of sexual pleasure, and it can be reinforced and then later just turn into a sexual arousing thing throughout the rest of their life. Individuals with paraphilic disorders often have very high sex drive. A lot of this is actually because suppressing unwanted fantasies increases them. It's the whole, don't think of purple elephants. Well, now you're thinking of purple elephants. Don't think of this thing that's causing you sexual desire. Well, but the act of trying to not think about it causes you to think about it more. So it's just one of those that it can, the sex drive and the sexual arousal associated with this object can become worse and worse and worse as a kind of reciprocal type thing. So as far as interventions, there are some really good interventions that are out there, some really strong interventions. First, targeting any deviant or inappropriate sexual associations are done by therapists. Covert sensitization can occur. So this is where you imagine aversive consequences to form negative associations. This is where those who maybe have a pedophilia, they have the sexual desire associated with prepubescent children, and if anytime they have those thoughts about a prepubescent child, they at the same time imagine the aversive consequences, like going to prison. Specifically what would happen to them in prison, because prisons are not kind to pedophiles. So when you're looking at that, if that person, if they start to strongly associate the negative consequences with that, with those thoughts, then they will, just by learning theory, they will decrease the frequency of those thoughts because of the negative associations that are being formed. Sometimes covert sensitization can occur with rubber bands. This is another thing you'll see. So somebody puts a rubber band around their wrist, and anytime they have these desires or thoughts about things that are inappropriate, they snap their wrist. It has mixed results. Some people it works on, some people it actually just makes them associate pain with pleasure, and it can actually sometimes make things worse. Another thing is orgasmic reconditioning. So this is masturbating to appropriate stimuli. Again, this is for typically cases of pedophilia, but at the same time, you've got various different ones of these paraphilias that we've been talking about, that if you masturbate to appropriate stimuli, you associate more of the appropriate stimuli with the pleasure rather than the inappropriate stimuli. There are other more extreme treatments like drug treatments. First of all, there's chemical castration. This is a chemical that actually basically eliminates testosterone in the body. So this reduces desire and fantasy dramatically. However, after the drug is removed, they often return. So this is something that would have to be a lifelong thing. And related to that, any type of testosterone reduction. Uh, this is especially in dangerous sexual offenders. The reduction of testosterone or elimination of testosterone in the body basically eliminates desire and arousal because the person cannot physically get aroused. So by taking these drugs, testosterone reduction or the chemical castration, these types of things, the person's inappropriate sexual arousals completely go away, and or if not completely, mostly go away. And in cases like this might be the only way for someone to avoid prison, or if they have been in prison, to be a normal member of society where they don't have these strong desires that they end up going out and acting on. Okay, the last thing we're going to talk about real quick is gender dysphoria. So gender dysphoria is feeling trapped in the body of the wrong sex. So we talked about sex and gender. Gender dysphoria is transgendered, someone who feels like they are trapped in the body of someone who is a different sex than they feel their gender is. So people with this often assume the identity of the desired sex. As far as causes, it's traced back to actually about 18 to 36 months of age, because gender identity begins at about that age and continues throughout the lifespan from that point. And it does need to be pointed out, just like we've pointed out with some of the other ones, it is not inherently a disorder. It's only a disorder if it causes significant distress or impairment. Very clear, it's not a disorder unless it's causing significant distress or impairment to the individual. As far as statistics we have, it's relatively rare. The numbers are actually higher than this now because it's becoming more accepted. But before it was accepted, these are the amount that displayed these characteristics. So between 5 to 14 per thousand males, and between 2 to 3 per thousand females. Again, the numbers are becoming higher now because it's more accepted, so people who have felt this all along are becoming more open about it. And one thing that's interesting is the rates are similar across all cultures. So the rates that actually have these types of feelings are similar even in cultures that are open or closed. I said more are displaying it now, but it's not necessarily more that are having these feelings, it's just more that are being open about these feelings. So if it's cross-cultural, this is more of a genetic thing than it is a social thing. One treatment that is out there is sex reassignment surgery. It's very restricted, or it tends to be very restricted, so a person has to be psychologically and socially stable and live as the desired gender for several years. And actually 75% report satisfaction with their new identity, and not just with sex reassignment surgery, but 75% report satisfaction with the new identity when they're out expressing their new identity. Female to males conversions adjust better. I do point this out, that in one of my classes in the past, it got me. There was a girl who worked in a medical facility that did these types of surgeries, and she said that a lot of people that end up getting these surgeries end up dissatisfied with the surgery. They're not dissatisfied with living as a new identity, they're dissatisfied with the surgery simply because a lot of nerve endings can be damaged in the process, things like that. And as a result, people who get these types of full surgeries, when we're talking about genital surgeries, they may lose their ability to derive as much sexual pleasure as they did before. I got to researching that and looked at it, and yes, there's especially since these surgeries are newer now, it's actually the rates of dissatisfaction are going down as time goes on, and these surgeries are becoming better, or the doctors are becoming better at performing these surgeries. As far as treatment for gender nonconformity, we're not just talking about gender dysphoria. Here we're talking about gender nonconformity in children. First of all, gender nonconformity is actually common in children. A lot of children express characteristics of the opposite gender, androgyny, as we talked about in a previous set of slides. That is more of a common thing rather than uncommon. So gender nonconformity is pretty common in a lot of cases does not lead to gender dysphoria. It can lead to negative social experiences, especially if individuals or especially adults are being strict about what is appropriate and inappropriate for specific genders, those types of things. So there can be negative consequences there. And if there's treatment, not necessarily saying there should, but it should be very individualized to the specific child's needs and environment. I'm not a fan of this unless it's causing, again, harm or distress. So when we look at it there, it's one of those things. Gender nonconformity, as I said when I was talking about androgyny, it's becoming more and more normal. It's not necessarily something to look at in a negative way. So to sum up these slides, we looked at paraphilic disorders and how they represent inappropriate sexual attractions. We looked at some of the treatments, and then we finished with gender dysphoria, being trapped in the body of someone of the opposite sex. Thank you. Come on back.